Good afternoon, everyone. Welcome to the Malcolm Renfrew Interdisciplinary Colloquium for Tuesday, September 8th. I'd like also to welcome my co-coordinator, Dan Bukovich, who you may see on your screen with the roof of the Kivy Dome in his background there. This is a weekly series of presentations by faculty, graduate students, postdocs, research fellows, with an association to the University of Idaho, as well as with Washington State University later this semester. This is the 20th year of the Renfrew Colloquium, bringing you presentations about research, creative activity, innovative teaching, outreach, and extension. Before introducing today's speaker, let me tell you a little bit about next week. We are continuing the theme of topics related to COVID-19, to epidemiology, to the pandemic, to vaccines. And we have a team of 4 presenters next week, September 15th. Bert Baumgartner and Florian Justwan from Politics and Philosophy will be joined by Craig Miller from Biological Sciences and Ben Reidenauer from Mathematics and Statistics. And their topic is some social science research about the risk of disease and the willingness to be vaccinated in the United States. And I hope you will come back for that program. And if you're not a subscriber to the Renfrew Colloquium email list, please go to our site, which is uidaho.edu/class/MRIC, and you'll see a link where you can fill out a form and join the subscriber list. Today, our presenter is Dr. Thibault Stalder from the Department of Biological Sciences, who has been working with Professor Eva Top on the use of wastewater as a possible detection and prediction of COVID-19, especially in rural communities. And it's a topic that's very much in the news as we read and hear about universities in other places that are using wastewater tests to detect the presence of COVID-19 in the waste stream. And so it's a great honor to have this very timely presentation, and I will turn it over to Dr. Stalder to begin today's presentation. Feel free to put questions into the chat function, and we'll try to get to those at the end of the hour. So thank you. Thibault.
Thank you for the introduction, Kenton, and thank you for everyone to attend this seminar. So as Kenton said, I work in the laboratory of Dr. Eva Top, where my research interest is actually on antimicrobial resistance, so something very different. But I have a particular focus on environmental spread of antimicrobial resistance, and during my PhD, I worked actually on how wastewater can spread antimicrobial resistance, which lead me today to talk about how basically how poop and pee can tell us a lot of things about the global health in a community, and how this could help us to maybe have a better surveillance of the COVID-19 and eventually, why not, predict COVID-19 outbreak. So before going into the wastewater surveillance, I like to go first about what is the current surveillance system is, and maybe some of the limitation. Sorry. I'll have to put up the screen option. Yes, that's gonna work better that way. Okay, so current surveillance is done by clinical symptom-based testing, which means in a population, for example, here with green susceptible individuals, someone will show up some symptoms like fever or cough, showing that that person might have been infected by the coronavirus disease 2019, otherwise known COVID-19, here with a little virus head. And that person will decide or not to go get tested to his local provider. And so we'll go to the hospital here and get tested. So current test there's currently several different tests that have been can be done, but the golden standard for detection of the SARS-CoV-2, which is the agent of the virus that is causing the COVID-19, is molecular testing using RT-qPCR, it's called, in biological samples. And so the biological samples can be a nasal swab, where the goal is to try to capture a virus that will be like in the nose, and then that virus will be lysed, and the genetic material, that is RNA in that case, will be extracted. And then we can reverse transcript, convert that RNA into a DNA molecule that could be used to detect that specific DNA molecule using PCR. And so the way it works is basically by amplifying tiny amount of that RNA into a large amount enough that can be detected by the instrument, and that detection is done using light, a light fluorescence system. Concerning the biological samples, it looks like there is like different way that can be done, and there's like apparently like a new test that is coming using saliva, but it's still based on molecular testing. So let's say that person get tested positive, and then like that will be quarantined, and that will like trigger like a case investigation workflow where that person will be like quarantined, and the people like healthcare authorities will try to contact the person contact that have been over the last few days and trying to mitigate the spread of that virus. The problem is that by the time that everything happening, there's more people in that community that showed up with symptoms and that gets tested or not. And so despite all the best effort to try to test people, but the virus still like spreading through communities. So it seems that the clinical symptom-based testing is failing to detect early warning of an outbreak, because like when the virus is detected into a community, basically it means that it's already well spread in this community and might be difficult to contain the outbreak. And also that's mainly due to the fact that, this clinical-based testing is also failing to provide good estimate of the prevalence of the COVID-19 in large population. And that's because a large proportion of the people doesn't show our symptoms, or the symptoms are not detected, like the virus is not detected in the population, making like difficult to get a good estimate, so the public health can have like a efficient response. And so that's mainly what I was just saying, because transmission seems to be largely driven by infected persons that are not detected by surveillance system. And by not detected, it can be different type. It can be people that are asymptomatic, so people that are infected by the virus, but doesn't show any symptoms. And so they will not show symptoms at all, or will show symptoms after like a couple days, or people that have mild to moderate symptoms, or just like because like of a poor surveillance system that cannot detect efficiently people. So here, back to our like system, is probably what happened here is I added like this hypothetical scenario, asymptomatic person. And so when that person got started to get symptoms, it probably infected several other people. And that can happen before even the person starts to get the symptoms. And so that's probably happened in that case, like 4.5 days before the person started to get the symptoms showing up. And that's what has been, this is kind of like the average time it takes from the infection to symptom onset. So here you got this distribution of like a density function of like of the probability of the function of the time from 0 to like 15. And most people show the symptoms after 4.5 days. And during that time, this person might have like spread the virus to other people. And actually like most research like seems to point out that the peak of infectiousness of someone is 1 or 2 days before symptom onset. So that makes that pandemic like very difficult to contain. So because when you got that first person that got infected go to get tested, more people get infected and so on. And that's even more difficult when here you got this example of this person that stay asymptomatic all the time in the population and can continue to infect more people. So based on those data from the Wuhan outbreak, for example, people estimated the R naught, so which is the number of people that would have been infected by a single person at the time that person got detected, to be 5.7. So that means in that case here, by the time the persons get detected, there would have been like 5.7 people that would have been infected. And the goal is to have this R naught to be 1 or below 1, which means that the virus doesn't reproduce into the population. Based on that, the same like Brazil study, we're doing predictions. So that's where like good data are very important, good surveillance are very important to predict and contain an outbreak. And so those data here, so using those data from the Wuhan outbreak, the people have been estimating how much reduction we will need of overall of our overall contact to have this R naught of 1 or below. So basically to erase that an outbreak based on the percentage of person undetected. So here 0 means that every people that have the virus will be detected. And in that case, we will need to have like at least 50% of our reduction of our overall contact to not have the spread of the virus, or we will need to have at least 50% of the people that have been infected and all their surrounding people that have been in contact being quarantined. However, the data seems to show that right now we are more at 50% people that are not detected because asymptomatic or not enough testing. And so you can see here that in this case, with 50% of undetected people, we will need to reduce at least set by 75% our like global overall social contact. So those data really show that active surveillance and contact tracing, quarantine, or an early strong social distancing effort are needed to stop the virus transmission, and that without a good surveillance, it's difficult to predict and contain outbreaks in a timely manner. And so that's lead me to talk about like, how can we flatten this curve that has been like a little bit everywhere on the social media, where people using models and simulation of infection are trying to predict the appearance of peak and trying to gauge the effect of different control strategy that would have on that peak. And those models are based on the numbers that we get. And so without good numbers of like how much people in the population are infected, it is difficult to do those predictions. Another like limitation of the clinical symptoms-based testing is the limited access to clinical testing in some area. So for example, like in rural area, it might be more difficult for someone to reach like a hospital or local health, like a provider, than someone that live in a big city. Also, what has been shown in this survey here, that it shows on this map of the USA, it seems that the tested is still, the amount of testing done is still limited. As you can see, like you have like for each state a color that represents the positive rate of daily new coronavirus test, and that are above 5%. So you can see that, I cannot see actually on my screen, it's hidden here by all the people. But you can see that actually for most of the state in the USA, that positive rate is still above 5%. And according to the World Health Organization, it's been estimating that that positive like rate need to be below 5% to show that the efforts of like sampling the population and testing the population is good enough. So there's still a limiting testing done on that. So now the question is, how can we improve surveillance? How can we go from this situation we are in the epidemic phase, which is basically having an amplification of amplification of the virus through population and trying to find control and mitigation strategy that hasn't been working well for eliminating or eventually eradicate the virus. But how can we avoid that? And so one way could be to, if we could have an earlier detection of the virus in population, then we could maybe have strategy of more local strategy of containment to avoid to go into the amplification phase. And so in that case, that's represented by my little scenario at the beginning. It will be if we could detect those people really early on, then we could either test better the local population or quarantine the area to avoid spread of the virus. On that, before going into the wastewater-based testing and how it could help us into that task, let's see how the virus basically, where can we detect the virus? So here's this little slide. I'm not a virologist, so I'm not gonna go into detail at all much on the virus, and I will leave that for other people later, I think during this, that's gonna give talk during the semester on this topic. But so the virus is the SARS-CoV-2, and I wanted to show you this picture that is very nice. It's like a transmission electron micrograph of a negatively stained SARS-CoV-2 that was actually slightly damaged here, and you can see the RNA inside. And so that's virus is an enveloped virus of the family of the coronaviruses. And it's like I was saying, the genetic material is a RNA. It's actually a single strand positive sense RNA virus. And what is interesting in our case, more like an epidemiology perspective, is where's the viral, where are we shedding this virus? So for now, it seems very evident, very clear that most of the transmission is through respiratory transmission between people, either by respiratory droplets or mutual interaction with surfaces, or as well as by aerosols. But it's been suggested that they might have some other routes of transmission that are told not clear if those transmission pathways are important though in the spread of the coronavirus disease. And so those have been mostly a fecal oral transmission. So the evidence show that it's possible that the virus could replicate in other organs than in the lungs. And so those evidence are based on the fact that receptors that the virus used to attach to the cell to infect the cell, that is this AC2 levels, are not only expressed in the lung, but they're expressed in other organs, where actually some biological sample from those organs, people found the RNA of the virus in those different organs. And so it leads people to think that maybe there is the virus might replicate into that. Some people found the virus to be still infective, for example, in the intestine. Some found to not be infective. So there's still a lot of discussion about whether or not there is potential for fecal oral transmission. But one thing that is sure is that the virus is shedding through the stool of people. And so when we look at, people looked at the dynamic of the shedding over time, and so that's what this graph is an example. So that study sampled after, patients after symptom onset, and that's the number of days after symptom onset, and look at the quantify the amount of viral RNA in those different samples. If it was a sputum here, swab here in yellow, and in gray is a stool. And so despite the fact that at the beginning, they all start with roughly the same concentration, it's very evident that this study and other studies found that the detection of the virus in stool and sputum is prolonged, is longer in those biological materials, sorry, compared to the swab, compared to a swab. Those studies actually use those dynamic to predict that the infectious peak of someone infected will happen before or at the symptom onset. So that's a first interesting things. And so since it seems that the virus sheds through the stool, is like, does everyone, another question we can ask is, does everyone shed the virus through the stools? And so there's already like 8 studies here, but I think now we're more at 10 studies that looked at the prevalence of like viral shedding through the stool among patients, among positive patients, and that prevalence is about half. So about half the people that are infected shed the virus through the stool. However, it seems that there is no correlation between the people that have like symptoms, like gastrointestinal symptom associated with COVID-19 and the detection into the stool. So there is like more research need to be done. But now, like the fact that at least half people that are getting infected shed the virus to the stool bring this idea that if it's got to the stool, it could be detected in the wastewater. And so that brings this whole new concept that wastewater-based epidemiology could be a good tool to trying to like estimate the proportion of like of the population that will be infected by the coronavirus. And so the postulate of wastewater-based epidemiology is that the community wastewater represents a snapshot of the public health at a certain time, and that using that approach, someone could like detect in real time, almost real time, like the spread of infectious disease or resistant spread or the emergence of like disease outbreak at the community level. And that little slide here is representing like the life cycle of like pharmaceuticals, specifically antibiotics. And that's a project I've been working, a European project I was working on before coming here during my PhD, where the goal, for example, was the decision makers funding the project to try to understand whether or not hospitals were contributing to the spread of antimicrobial resistance and antibiotics that arrive in wastewater treatment plants, which unfortunately doesn't like treat, and that can end up in the environment. And so using that kind of like approach, we were able to quantify, in my case, on antimicrobial resistance, we were able to find that, for example, at the city level, we were like the city we were like studying, there is like only 14% of the, using biomarker of antimicrobial resistance, we could find like that 14% of the load of antimicrobial resistance arriving in the wastewater treatment plant were coming from the hospital effluent. But actually the major fraction of like the antimicrobial resistance arriving in the wastewater treatment plant were coming from residential effluent. So that's kind of give you a little bit how useful it can be, this wastewater testing can be useful for a lot of like a decision making. And that's actually is not new, that type of approach. And wastewater-based epidemiology were at first used in the early 2000s to study the behaviors of drug consumption, like cocaine and heroin. And so there is a couple studies in Europe. The one on the left is a study in France, and the one on the right is a study in Italy, where they're trying to understand the behavior like of drug consumption of, like I put just a couple of them here, over the week and weekend, and over like also a geographic area. And here, for example, you can clearly see that depending on the drug, the consumption are not the same on different geographic scales. So for example, cocaine seemed in France to be used more in northern France, while MDMA was more important in the south of France, with like a peak of consumption during the weekend. And that's the same in this study in Italy that was looking at like a residual amount of illicit drug in the wastewater, and that clearly saw that there is like a peak of like, so I cannot like see, I cannot hide that, sorry, I'll try to do something. Can I remove this? No. Well, anyway, there is like a peak of, I think it's methamphetamine. I cannot see what I'm pointing out really during the weekend. So you can see, it seems that this type of drug are more associated, or ecstasy are more associated with like a weekend consumption than THC, that is like a more consumption during the whole week. So based on that, like how does that kind of approach, like wastewater-based epidemiology, can help us with the current like COVID-19 crisis. So the idea is that if we could, so we know the people like shed like a virus through the stools. So if we can detect and quantify that virus in the wastewater, we could in a timely, very timely, like inform like the public health response, like public health that could have like a very quick outbreak response to try to contain that pandemic. And that's what studies like early in April, some people starting to publish that you could detect the virus in the wastewater. And some of the first time series where people quantify the virus over time were also published in late April. And that study, like one of the first one was like shown like in the Parisian, like a wastewater, they quantify the SARS-CoV-2 in the wastewater even before the first detection of like cases. And so here you got the concentration shows on the top graph, and on the bottom graph, the light gray shading is representing the number of consultation for COVID-19 symptoms. So it's even not a detection. But what you could see in this really early like graph is that it seemed that the concentration of the virus in the wastewater follow the trend here of the consultation of COVID-19. So it seems really that that could be a tool that could be like useful. And also like here they looked that the left shows the before and after quarantine. And so that's kind of like trying to see if there's an effect or not. Well, since then, that type of approach really picked up, and a lot of people over the summer starting to publish articles where they detected and quantified the SARS-CoV-2 in wastewater, and that's what shows on this map. So it's today like up-to-date map of all the studies that have been published in the peer-review or non-peer-reviewed journal where people have been detecting the virus in the wastewater. And so you can see it's like a very international effort. And I'm not gonna detail all the studies, but I just put a few of them that really show like how wastewater based, how testing wastewater can be useful to predict like COVID-19 outbreak in communities. So the first one on the left here show you the viral titers per copy per ml and over time, and that was in the Boston area. And in blue is the viral titers, and in orange is new cases. And so you can see like the best fit here of the curves that is represented by those shadow line here, that the viral titers comes right before, like the trend of the viral titer first follow the trend of the new cases. So when it goes up, and when it goes down, it goes down. And what is important too is that it's foreshadow, like the concentration in the wastewater foreshadow like the detection by the public health authorities. And here, that little lag time was about 4.5 days. And another study found the same. It was around about 4 days too. Another study where they found in the wastewater, that's a concentration of the virus in red, and in black is here's a detection of new cases in the same area. And you can see that there's definitely the trends follow, and there is always like the detection of the virus is always happening before. You can detect before in the wastewater than it's been detected by the public health authorities. And so that's very important, because what those studies shows is that wastewater-based testing can detect the virus in the population before symptom-based testing. It can provide a good estimate of the prevalence in population. And very importantly too, it's cost effective, because just by sampling like a single point every day, you can get a general overview of the spread of the virus into a population. So here, like all the different things that it can be used to. So and that's will be interesting to investigate is like, does this now, can we with wastewater-based testing, can we use that as an early warning of an outbreak? Can we use that for tracking also the impact of medical and social intervention? So for example, like look at the trend and look at the trend after quarantine, for example, or like any type of rules that could be applied to a certain area. Identify area of concern. certain neighborhood where maybe the transmission might be more important than other neighborhood. You could sample like the sewage network to really target some of the neighborhood. You can also like deploy this type of testing in area that has limited testing, such as like rural area. Maybe we could use also wastewater-based testing for prediction. So it seems as those data really like the trend of the wastewater follow the trend of the cases that are detected. So maybe we could use the viral titer to predict a peak in an outbreak. And also, like it's been suggested that evolution of the virus could be tracked in the wastewater. If we can sequence the virus in the wastewater, one could look at the mutations that arise in the population over time. On that, what we've been doing at the University of Idaho, I'll present what we've been doing at the University of Idaho. So following those publications and fostered by a few people of IMCI, we put a team together to trying to establish a protocol to detect and quantify the SARS-CoV-2 in wastewater over the summer, and trying to see if we can use that approach to inform our local community. And in the future, we'd like to try to leverage those data collected to see if we can predict outbreak in rural communities. I'll start with like our protocol. So how do we detect the virus in wastewater? So it starts going to the wastewater and collecting sample. And for that, we use what's called a 24-hour composite samples. So that type of samples are done by wastewater treatment plant, and it consists of a sample that is representative of all the water that went through the pipe over the last 24 hours. So you could imagine the flow of the water is variable during the day, and you can set up like a sampler to say, take 1 ml every so gallon of water that go through that pipe. So then the sample you collect is some sort of an average of a wastewater that went through that pipes. So we collect those samples and we first remove the debris using filtration. We've been trying with centrifugation, but now we use filtration. And the virus is so small that it goes through these first filters and being present in the filtrate. And then we have a large volume of filtrates that we need to shrink down to a smaller volume that we can use to extract total RNA. So that's kind of a concentration step. So we're trying to concentrate this volume of water to a smaller volume where we have more virus per ml. And so to do that, we've been testing two different methods. One that is a flocculation precipitation using polyethylene glycol. The way it works is you have a chemical, and that chemical helps the viral particle to precipitate. So then you can try to recover them in your precipitate and resuspend them in a small volume of water. And the other method is using centrifugal ultrafiltration. So the way it works is you add here on the tube, you got like your filtrate on the top, and the separation here as a filter with tiny, tiny pores that are so small that the virus cannot go through, but the water can go through. So using centrifugation, you can pull the water out of your sample and reduce that volume to by 10 times, roughly. And then with the small volumes, we can extract the total RNA. And from there, the approach we're using is very similar to what is used in clinical testing. So we deactivate the virus, extract the total RNA, and then we use the same approach like as CDC for the RT-qPCR detection with similar chemicals. We detect the virus in our extract. What I want to emphasize is that for this type of like for wastewater detection, there is no standard protocol like a standard protocol that you like in public health where you follow all the steps exactly how it works. It's really like at the experimental stage still. A lot of people in the literature use different protocols, and it seems to work differently. And the main difference is really this concentration of the viral fraction. There's no ideal way to do that. So what we wanted to do is to try ourselves to see which method we wanted to use. And to do that, we needed to have some sort of an idea of how much virus we lose at every steps, right? Every step you might like lose a little bit of your virus. So what we did is we use a surrogate virus, mouse coronavirus, that was provided by Dr. Tanya Mura from the department, who's working on coronavirus. And the advantage of using that virus is that, first of all, it's like a virus that is not dangerous like for a human, and that is different enough from the SARS-CoV-2 that we can differentiate by RT-qPCR. And we have a titer of that virus that we can add to our wastewater to a known amount. So then we can extract our like coronaviruses, we'll say, through our old process, and we can quantify how much MHV strains, so this mouse coronavirus we recovered, and we can calculate the recovery, percent of recovery based on how many we added at the beginning. And so that's kind of like our preliminary data we got over the summer, and found that using ultra filtration, we were having 10 times a recovery rate that was 10 times better than using like a polyethylene glycol. So that set us up with a protocol where we decided to use ultrafiltration. Fortunately, that's also what most of the people in the literature seems to report, is that this type of concentration method is what works the best. So with that method in the end, we started to monitor like the concentration of the virus at the Moscow wastewater treatment plant. And so we've been sampling this, we've been receiving sample from them since the 1st of July, but we've been processed sample like of late August, and we'll go back to our freezer to trying to see what was the trend since July to now. But what it seems to happen is we observe like a gradual increase of the concentration of the virus in the wastewater from August 17 to August 27. And another like interesting data and another issue that is a challenge, I'll say, called a challenge of working with wastewater, is how do you tie the concentration in the wastewater to some meaningful data for the at the population size, because the population change over time, especially in a town like Moscow, where students came back at the end of August. So does it increase because there is more students in town? And so to do that, we need to normalize our data to some sort of an idea of the population that was present at each time point. Luckily, we can do that because wastewater treatment plants measure some contaminants that are very specific to residential area that are produced by people. So by quantifying those contaminants, then we can have an idea per day, like how much of those contaminants arrive at the wastewater, and we can normalize our data. And so those are called like a BOD5, like biological oxygen demand after 5 days, or total suspended solid. And so we see, I'm not gonna go into the detail, but you can ask me a question after if you want. But what is important to see is that after normalization, we really see that this increase happened between like August 20 and August 27. Another challenge we're facing with the detection of the coronavirus, like the SARS-CoV-2 into wastewater, is that despite that you see those concentration per liter seems important, like the number of copies that the instrument is detecting is really, really low, and we're really at the detection limit, which makes that there is sometimes a lot of variability in our quantification, and it might be an issue when we're gonna measure the trend over time and trying to do statistics with that. So our future work is trying to determine the limit of detection of quantification, of our approach, but also see if there's any inhibitory compound that can come to inhibit the PCR reaction, the enzyme that make that PCR reaction and that make like a bias our numbers. On that note, I like to say that so there's Biorad that has another type of like instrument, and like here I'm talking maybe for people that use a qPCR for detection of genes in their work, and might have been heard about droplet digital PCR. and it's been shown that it has a better sensitivity and accuracy than RT-qPCR and that the qPCR. And actually, Bio-Rad had the FDA emergency use authorization for the detection of the SARS-CoV-2. It's for in biological samples, and especially, and it works very well for wastewater detection. So if there's anyone in the audience today that for their research ever thought about, oh, water droplet digital PCR will help me in my research, please contact me, because I've been in contact with the people from Bio-Rad, and that instrument is somehow quite expensive, but maybe if we have a lot of people interested, maybe we could try to get all together and acquire such instruments at University of Idaho. Finally, and probably you heard about it today, but wastewater testing has been shown to be useful for university. And there's a couple headlines that came up since September with several universities that use this type of approach to monitor dorms and see if there is like a population of students that will basically be infected. And it seems that it was quite successful in several universities, such as Utah State or Arizona State University, where they were able to maybe prevent like start of an outbreak by testing like the wastewater. So in the case of Arizona State, they monitor like their dormitory, and on the morning they take a samples, and by the end of the day, they got the result that that sample was positive. Then the next day, they were able to test the entire dormitory, like each student in the dormitory, and found, I think, 2 students that were asymptomatic but carrying the virus. So they were able to quarantine them. So with that, it's give you an idea about how we could use that here at the University of Idaho. And actually, we starting since last week, and we probably saw that in the memos from President Green this morning. So thanks to like the effort of our team and the facility, last week we were able to collect wastewater from 8 residential locations on campus that allowed us like to quantify, to detect the presence of the virus in specific residential area on campus. And so using that approach, we can really could identify if there's infection in certain area of the campus, and that could be really like a tool to complement the framework that is currently being deployed at the university. And so as you saw this morning in President Green memos, we found like 2 areas, at least 2 residential area where we detected the virus in the wastewater. On that, I will continue and say what's our future work will be. So we'll like to leverage the data that we collect from the wastewater to trying to see if we could predict an outbreak in rural communities, because rural communities have higher risk of having a severe outcome with the COVID-19, and also have less access to testing probably. And so we think that wastewater detection could be really helping those communities to monitor the spread of the virus. On that, I'd like to thank the team. I would really like to emphasize that as a team effort, and I'd like to thank actually, like especially Cindy, who is working with Eric Coates, that is a person that is at the bench every day trying produce all the data that are presented here, and that just got joined by Erin Mack in this effort to trying to produce like more data. And on that, I'd like to thank also like Dr. Eric Tubb, Eva Tubb, Eric Coates, and Ben Riedenauer for the support, and also like our weekly meetings and brainstorming about like how we're gonna like all the strategy around that project. And I'd like to thank our funding, so IMCI, that helped us at the beginning really to start that project, to kick up, like really get that project started, but especially the discretionary funds from Top and Riedenauer and Coates Lab that make that project possible. And today, last week, we were able to start monitoring that, doing campus monitoring. On that note, I'd like to thank all for your attention. And if you have any question, welcome. Thank you.
Thank you, Thibault, and for an informative and very timely presentation. And we have a series of questions in the chat, but I'd like you to go back to the slide with the campus map. And if you could tell us how those 8 residential locations were selected and how you're able to isolate samples from those areas, and if you're able to say which were the 2 residential areas that had showed a higher level of COVID shedding.
For the last question, I don't know if I can share or not those data. I will say where exactly it was found. I think I would leave that to the university administration to see if they want to communicate that. But for the first question, for sure, what basically we've been looking, thanks to the facility has a map of all the sewer network. And so we basically can isolate with manhole at the exit of every buildings, or exits for example, at the exit of each of the building on the east side or the west side of a residential area, or the Greek road that we can trying to capture in a manhole that basically collect all the wastewater from those area, right? And so for now, we got 8 of those locations that give us an overview of residential areas that are trying to, you basically want to have residential area without any other sewers that come from other, I don't know, from the city, for example, or other building where people works. So the wastewater sewers that goes out of the building sometimes have a manhole right at that is accessible. And so the people from the facility can go there and just sample the water. So for now, because it's very recent, we started that, we do what's called a grab sample. So it's just a sample that we take at the morning at 8:30. It's really a shoot in the dark because it's not the perfect type of sampling, like the type we do at the wastewater treatment plant, where it's all the wastewater over time that has been sampled. And so here is really a shot in the dark about 8:30 on the morning, picking a wastewater and hoping to capture what's the people in those buildings through that the toilets basically what came out. So for now we only have that, but in the future it will be interesting to do either more sampling during the day or maybe install some of those samplers, but that can be difficult. I don't know if it answers the question.
Yeah, that's helpful. Thank you. So Thibault, if you could stop the screen sharing and so that we could see everyone who's in the audience today. And if you're in the audience and would like to ask a question face-to-face by turning on your camera and unmuting, you could go ahead and just raise your hand in the Zoom function. But I'm going to start through some of these questions. Jennifer is wondering, how large were the studies on the time dependence of viral shedding? If that question makes sense, or if Jennifer, if you'd like to jump in with a little more clarification on that.
I have a little more maybe focused of a question that's related to that. So you showed earlier the slides that had the swab and the fecal and the sputum testing on time dependent way. And I think other things that I've read have indicated that the amount of virus shed varies a lot depending on the person as well. And so I was wondering both how large the samples were in those studies where they looked at the 3 different methods of detection, and then also what you think about sort of the population size of Moscow, and that really, the 4-day sort of extra time that we get from wastewater as opposed to waiting for case. How is our smaller population size going to affect that interval, right? Do we have enough here?
So the first one, like on the paper, I will say I don't remember exactly how many people they tested, but I think it was like, there's several of them, but one I think was like only 15 people, I think, or it was pretty little, like a small size. And so then the methods of detection, I can imagine, can be very important. Also, like I just showed like the graph for two of the people, but they had like individual graph for every patient, and there is quite a variability. The really main conclusion on those is like from two different studies is that the shedding through the stool is definitely look longer than when you do like a throat swab or nose swab. And that's really like the important things. And the other studies also show that there is a significant decrease in the concentration that is rather quick from the symptom onset to later on. So that's kind of like what I will say, but I do not remember like the detail on the type of methodology they used. And now the second question is a very good question. Is like it's a good question that we don't know is how like a size of the population might affect that time before. That's something that we'll definitely need to look at with the time series starting like since end of August will help us with that. When we'll be able to compare that with like the case reported by the Lata County, and we'll be able to see if it's foreshadow and what is the time before. Yeah, no, it's a great point. Those studies were all done in major large cities, and so that's kind of like one of what we'd like to apply that for smaller communities, like rural communities. Moscow is not considered a rural community, but like, yeah, how does it apply when we go downscale a little bit?
Yeah, this is really exciting work. So thank you so much for telling us about it.
Thank you.
The next question comes from Yisol. I hope I pronounced that correctly. It's actually two questions. Should people be concerned about disease transmission via sewage? And second, have we detected intact virions or virions or only RNA fragments? So two questions, one broadly about public health and the other more specifically about what the tests are detecting.
So concerning the wastewater work, there is only one study that and that's only one study and very little small sample size that looked at the infectivity in the wastewater. That was a big question, especially when we started on that with the biosafety, of course, right? When we handle those samples, if there is a risk of transmission. While this only study didn't find any active or virus in the wastewater, and the CDC pointed out that it doesn't seem that the people working every day with wastewater, like in wastewater treatment, people handle wastewater around the world every day, and it doesn't seem that population show a higher prevalence of infection with the COVID-19. So this is really need more research, more data need to be collected to really have a strong indication. But the preliminary data doesn't seem to show that the wastewater will be a source of transmission of the virus, especially that that virus into the sewer system might be degraded rather rapidly. So what we detect is RNA might be inactivated particles. So the virus to be infective need to be integral virus with every of this protein, and it can still be inactivated a little bit like a broken, but still intact and being detecting in the wastewater. So we don't know if what we detect is free RNA, which I don't think it is, but mostly maybe broken particle of virus or virus that are intact but not infective. That's more like a personal thinking, but there's no data that shows that. What was the second question?
No, you answered. It was basically one question, so I think you covered it all. Thank you very much.
Yeah, there is not much data, and the fecal-oral transmission literature is very on the two sides. Some people argue that they don't find any infectious virus into stools, and it's very likely the global spread of the virus is probably not driven by oral fecal transmission. And some other argue that it can because some found infectious virus in the stools. And based on data also from the SARS first outbreak in China in 2003, there was like a case where an entire building got contaminated by a faulty sewer system. So some people argue that that could happen too, but there's definitely more data to on that.
Definitely. Thank you so much.
I'd like to ask a follow-up question, and this was what I sent you earlier in the email. Should we be concerned about aerosols emitted from toilets that are flushed, especially those without lids? And what have you read, or what can you suggest in terms of?
If I look at the World Health Organization recommendation, or about that, they say there is no clear evidence of fecal oral transmission. So they say that the evidence really is like transmission through the air, like oral, like a transmission of droplets, and there is no clear evidence. There's kind of like, there's some evidence, but it's not clear whether or not it's important and whether or not we should be concerned. So it's definitely like, will be like interesting if people show up like soon with some data about that.
There's another question in the chat from, I believe, Tomislav. What is your current false positive or false negative rate? And second, what level of specificity do you have for these primers, or are other coronaviruses also picked up by those primers? And so if the questioner would like to unmute and turn on the camera and elaborate on that, or Thibault, you could go ahead and respond.
Great. The first question is great. Is what we want to do. We do not know what is our positive rate, so our predictive negative value and our predictive positive value, and we actually like trying to get together a proposal for like a pilot grant for the IMCI, and one of our aim is actually to determine that, like, can we determine the predictive values, positive, like the chance that a positive test in the wastewater indicate like an outbreak is starting, right? Or what is the chance that if you don't detect in the wastewater, there's actually indeed no outbreak. So that's something we want to do in our future work. Concerning the specificity, our approach, we're using the same primer and probes from CDC, which target the N1 gene of the virus, which is like, and that is very specific, hasn't been shown to detect any other type of virus. We have, so yeah, that's what I would say, yeah. It's very, for that is very specific, yeah. There's others like primers in the literature that have been shown to be like maybe cross-react with other viruses, but those haven't been shown for that.
Holly, it looks like Aaron responded in the chat to your query about how expensive is the BioRad equipment. Would you like to follow up on that or expand on that at all?
That equipment, so it's very interesting. It's like, I think it's 100, I have like on my little notes around here.
Yeah,
$130,000 is that a piece of equipment. It's what's been mostly used in wastewater studies because it's not affected by the enzymatic reaction and the quantification you get from there. That is not affected as much by environmental contaminants that can be co-extracted with the RNA. And the way it works, it's much more accurate and sensitive, so you can like detect much lower amount of targets. And that type of approach as being like this type of instrument is used also for people determining like doing a RNA expression level, because it's like we'll say a little bit like more precise, so you can detect like fold change of RNA expression of a gene that are better, or detect like lower concentration of a gene in an environment. There's a lot of applications that are very interesting. It doesn't replace the qPCR machine because it has some other like also like it's basically very complementary with the two approach. But in the case of the SARS-CoV-2, the digital droplet PCR seems to be an asset. So yeah, 130,000 to 190,000, depending on the type of model and configuration. That's what I remember.
I don't see any other questions in chat, and I'm just scanning the audience real quick to see if there are any hands. Is there anyone who has...
Kenton, I have another question, but I can't figure out how to raise my hand on my phone.
All right, Rob.
Can I just barge in and ask?
Yes, go ahead, Rob Ely.
Thank you so much. I remember reading something about them detecting or deciding that there are about 4,000 cases in Moscow based on the most recent wastewater treatment survey that they did. And I'm curious, can that possibly be right?
So that's a great question. We've been debating that a lot with our team. So those numbers come from, so there's this company called BioBot that is provide like a testing of wastewater to a certain cost that is very expensive. And what they do, they quantify the virus in the wastewater, and somehow they estimate how many people will be infected by those numbers. But there's absolutely no peer review so on how they do that, right? It's kind of like they estimate, they normalize the concentration of the virus, and they somehow estimate maybe how many virus you got like in a stool in average per person, and they somehow go get a number, and those numbers that you saw like in the news, which are like 4,000, are probably very, very wrong. Like there's like absolutely like, there's a lot of levels where between concentration of a virus in the wastewater to like predicting the number of people that can be infected. And as you saw like in one of my slides, first, not everyone shedding the virus through the stools. And there is like, even if it's half people, the variation between the studies are very, like, can go from 20% of the people to 80% of the people. Also, there is no good numbers about the amount of virus shedded by someone. And those are, can be very low to very high. So it's very difficult. Like there is no one yet that came up with like a good way to calculate that. And that company a little bit mad that they publish those numbers with having, like, despite the fact that they can't, like the numbers they publish of kind of like the concentration, the method they use is published, they don't give any detail about how they calculate that numbers. And we think we probably think it's very wrong, yeah. And that's unfortunately what people focus on at the end.
So, Dan, go ahead, please unmute yourself and jump in.
Oh, I saw someone raising their hand and I cannot hear that person.
Okay, there.
Oh, there, go ahead.
You know, there was wastewater tested in one of the dorms this weekend, and there's a lot of confusion on campus with the kids involved in this particular dorm. Do you know anything about that?
What do you mean, the confusion? Oh, the confusion is what we heard maybe is water, that the water was tested is like, what is important is like the wastewater was tested. There is no problem with the drinking water, right?
No, but the wastewater was tested, and so the students are confused. Do you have to quarantine? What happens when that happens?
Oh, what happened? What happened? I don't know, but I'm not like totally 100% sure of what's the administration, what university is doing. So that's, I don't know if there's anyone in the audience that knows better about that and can kick in and answer that, but I don't know, no.
Yeah, because the students are quite confused as to what they should be doing.
Like whether they should like quarantine or get
yeah.
tested. I think they're gonna test like most of the people, if I'm right. And so get the people tested, that would be the best. I don't know what are the other, I saw some emails, but yeah, I'm not sure. Maybe someone.
So, can I say something?
Yes, Eva,
yeah.
Please.
So I don't know much more, but I guess from the memo of President Green, it's pretty clear that the students were asked not to go to class until the individual tests have come back, which sounds like it's not going to be until Friday. So that, yeah, I am not a decision maker, so I don't know what's best, honestly. Should they really quarantine when it's maybe only 1 or 2 students in a whole building that are positive? It is hard to know.
I'm
That's
looking
also
over
Thanks.
the audience and I'm not seeing anyone from Provost's office, Dean of Students, or our COVID-19 coordinator, which is a shame because I think that all of them would have benefited from this presentation. But I'm assuming that the Argonaut will be on top of this and probably have something online by the end of today. So Dan, appreciate your question, and I'm sorry that it's beyond the scope of today's presentation, but certainly very timely and well connected.
No, it's definitely like we really hope that that tool, like now we're gonna monitor twice a week, and we really hope that can help the task force of the university to do their testing and avoid like a spread. Yeah.
We've come to the end of our hour, and I appreciate all of you in the audience sticking in for this very detailed and thorough presentation about an important research area. And so before you go, I'd like you to join with a virtual round of applause, either with the clap sign on your screen or just if you're on camera to do that as well. So really wonderful to have you here, and we look forward to learning more about your research going forward. I hope everyone will join us next week for a team of 4 faculty members speaking about attitudes towards vaccines, which is a question that will take on greater importance if and when we actually have a vaccine. So thank you again, Thibault. Thank you, Renfrew attendees. Have a great rest of the week. Please stay home, stay healthy, stay safe.